Good afternoon, guys, or maybe good evening, depending upon when you're listening to this. This is our lesson on infection control, so let's get into it.
Shagadelic, yeah. You really have to be here for this to be. I mean, it's so strange. I don't believe in science. When it comes to the spy game, to me, it's all in. Sarin, we've discovered trace elements of a rare vegetable found only on one island here in the Caribbean. And it means that this is the location of King. Oh, this coffee smells nice. It's a bit nutty.
Okay, just a reminder, no food or drink in the clinical setting. All right, so we're going to talk about infection control for basic infectious agents. That would be the bacteria, the viruses, the parasitic protozoa, and the funguses. Steps involved in the establishment of infectious disease. It's important that we know those steps so we know how to break the chain of infection, in particular, breaking at the point of spread to another individual. We're going to talk about the microbial control within the host, that is the immune system response. We're going to talk about policies and procedures and methods for medical and surgical asepsis, which is basically two different levels of cleanliness, and we'll talk about chemical and physical methods, disinfectant agents, hot steam, autoclaves, those type of things, but also the personal protective equipment. And I am going to show you how to wash your hands correctly. Right, so in teaching you personal protective equipment and washing your hands correctly and germ theory and modes of transmission and spread and the chain of infection or cycle of infection, we want to establish standard precautions. These are basically behaviors that you instigate for each and every patient contact, because we start out on the premise that each and every patient contact is potentially a transmission event. So that's the philosophy, the grounding philosophy, the core idea of infection control is that every patient contact is potentially transmission of infectious agent. Okay. So we start out with our understanding of disease. Louis Pasteur, who is the father of germ theory, some people say the father of modern medicine, certainly between his discovery of germ theory and microorganisms, very, very tiny single cellular organisms, and now we include viruses, non-living single cell pathogens. Between that discovery in roughly the 1860s, I believe, and the discovery of X-ray, healthcare was revolutionized in the course of about 30 years into essentially its modern form. Okay. Now, then we've added insurance and the idea that everyone needs a certain standard of healthcare since then. But as far as the activities that we do and the way that we practice healthcare as a frontline practitioner, a lot of that was formulated on the tails of the discovery of germ theory and the discovery of X-ray. And a lot of the stuff we do now is, and a lot of the stuff we're capable of doing now is based off of, that's when medicine turned the corner into the modern age, is those two discoveries. Okay? So germ theory is essential, and on top of germ theory is the larger field of infection control, which is, okay, so we understand germ theory, how do we interrupt the spread of these microorganisms so that they can't do infections on additional hosts, okay? How do we break that cycle? That's what infection control is aiming at, okay? So we have to understand what infection is. Infection is an invasion of a multi-celled organism by single-celled pathogenic organisms, okay? There's 4 main types that we talked about just a second ago: bacteria, funguses, parasitic protozoa, and viruses. Okay, pathogens, regardless of those types, all basically do the same thing, and that's how we know that they're pathogenic. When they get inside the body, they multiply into a colony. They could cause obstructions in the tissues, or in the ducts and the channels, the regular conveyances, as we move water and nutrition and waste products around the body. The presence of these pathogens, if the colony is big enough, could obstruct the flow of the tissue. The nasal passages and a sinus infection is a good example of an obstruction type episode. Okay. Tissue damage, anytime you have an inflammation response, you do get some tissue damage. Infections do trigger, so long as you have a healthy immune system, they trigger an inflammation response, because the inflammation response actually brings in more white blood cells to the local area where the pathogen is present. So tissue damage is caused both directly and indirectly in an infection. The direct action of tissue damage is that third bullet, the exotoxins. These are basically the waste products of these pathogens. And if the colony is big enough, those waste products build up, and they actually are poisonous compounds to our body cells, certain types of body cells. And there's varying sensitivities depending upon what the exotoxin is. Some of the exotoxins are merely just irritating, while others are just downright hideous, all the way up to causing tissue necrosis. So those side effects, and when we say that we're sick because we feel lousy, a lot of times there's two causes for that. One is the inflammation response, but then the other one is the presence of the exotoxins causing some of those lousy feelings. Okay, so pathogens have 4 types. We exploit 2 of those types and make them into food just because we are creative people as human beings, and over the entire span of civilization. We figured out how to make wine and beer because the water from the river was making us sick, but wine and beer was not making us as sick. So we figured out how to make wine and beer. And then some of the wine spoiled, and that became soured, but that didn't make us sick either. So the spoiled wine, we call that vinegar now. Red wine vinegar is spoiled wine. Yogurt is spoiled cream. Cheese is spoiled cheese curds, fungus infection. So a mold growing on cheese curds, that's which is the solid components of, if you spoil milk and treat it with acid, then the proteins kind of clump together into curds, and then the rest is called whey, right? And so the whey gets strained off and the curds get clumped together, and then you press them, and then you let a fungus grow on those, and then the exotoxins of the fungus penetrate the curds and give them additional flavors. and that's what we call cheese. Okay. Now, viruses, we have not figured out a way to make viruses into food yet, but I'm sure that's coming in maybe another 20, 30 years. We'll figure something out. Parasitic protozoa, oh my God, these things are scary. I don't imagine we'll ever find a food use for parasitic protozoa. They're just, they're nasty little things. They are the hunters of all these things. Most of the first three, the bacteria, the viruses, and the fungus, are kind of passive. They're not actually trying to kill you. They're just trying to survive on their own. No, the parasitic protozoa is actually hunting your body cells and eating them. It is actually trying to devour you one cell at a time. They're nasty. They're awful. Okay, moving on. Okay. So the bacteria are, here's our first vocabulary term, and it's got an opposite coming up on an upcoming slide. Prokaryotes. These are simple cells, single-celled organisms, simple cells, just cytoplasm and a little bit of DNA and RNA swimming in there. No organelles. So the mitochondria is the powerhouse of the cell. No, not in a bacteria. The bacteria doesn't have a mitochondria. It doesn't have a nucleus. It doesn't have a Golgi apparatus. It doesn't have an endoplasmic reticulum. It doesn't have any of those things. No organelles at all. It's not very complex. It's the simplest of simple-celled organisms. It's just some DNA and RNA strands surrounded by a cell membrane and some cytoplasm. It does have a metabolism, but it doesn't have like organization where it's separated. The metabolism of a bacteria is just random. Okay, it absorbs nutrients, proteins, sugars, minerals, water from the environment and makes them into and replicates itself. And that's about all that a bacteria does. And then it squirts out waste products as it doesn't need any of those things anymore. So, and some of those waste products are like acetic acid. Other waste products are like carbon dioxide. So, bacteria come in some basic shapes, either spheres or rods or spirals. Okay, so you might have heard of streptococci or streptococcus. That is strep throat. That's a spherical bacteria. Okay. I believe tuberculosis is a bacilli. It's a rod-shaped bacteria. And now, just mentioning gram staining. Gram staining is how we see the bacteria on a slide. It's the purple dye. So if you've ever seen like a microscope slide picture or looked into an actual microscope slide at a bacteria and you noticed it was like a magenta color, well, that's not natural. That's an artificial dye that we've put in there, and the bacteria thinks it's a nutrient, so it absorbs it. And then the bacteria are essentially clear. It's very, very hard to see them unless you gram stain them. All right, so bacteria do colonize. That is, the whole point of a bacteria is to make more bacteria, and they can do this by themselves. They have the DNA and the RNA codes inside them, and they can replicate themselves, just like one of your body cells can replicate itself. Okay. Bacteria also have, in particular, in the bold here, C. diff forms spores, which you can think of as like dormant bacteria seeds. All right. So we have two methods of hand washing. It's vigorously running water and lots of foamy lather in soap, so soap and water, or alcohol foam when soap and water isn't available. We have to understand its spore behavior. So when C. diff understands that it's in a non-nutritive environment, that is, it thinks it's going to die, it starts shedding endospores. It starts shedding seeds. And those seeds just spread throughout the environment and they could travel. C. diff likes to stay in your gut and give you diarrhea. So the spores get into the bed sheets. Okay. We have to know this because if we do portable x-rays on a C. diff patient, we have to be sure that we're washing our hands with soap and water after we x-ray the patient, because the alcohol foam won't get rid of any of the spores that we've come in contact with. All right, so viruses, these are zombie microbes or zombie microorganisms. They do have a cellular membrane. They usually have little projectiles that are not for self-motility, more for tethering, and that's how they replicate themselves. The tethering is the first part of the replication. So a virus floats along until it encounters another cell, a living cell. It could be a body cell. In the case of what we want to understand, it's one of our body cells. The virus has these little tethers that make it attached to, so it grabs the cell membrane and then it tears a hole in it and injects its contents into the cell. Okay, those contents are DNA and RNA strands that are viral replicating codes. Okay, so a virus will hijack a body cell, take over the metabolism to start making more viruses until it uses up all the resources and it bursts the cell membrane, and the viruses from the explosion of the dead cell that was completely used up, more viral particles start spreading through the body. So it's really insidious little thing. Now most viruses are just like annoyances, where there's tons and tons of viruses. There are some serious ones. Influenza is a pretty serious one. Coronavirus was a serious one. It's getting less and less serious. People are still suffering from it, but it's the chance of fatality is reducing dramatically with these later variants of coronavirus. The common cold, rhinovirus, is a not so serious virus. It makes you feel bad if you get it, but typically it does not cause you, to lapse into a coma or die or anything like that, unless you're severely immunocompromised. Then everything is serious at that point. Okay. Viruses are technically not alive. They don't become metabolically active until they hijack a cell. They're very much like the endospores, except for they don't. The endospores can turn into a full bacteria once it figures out that it's in a pleasant environment. The viruses never turn into anything with an active metabolism until they tether and invade a host cell. Okay. All right, so what's the size of a virus? This is critical to understand because that was part of the problem with the masks. The filtration of a regular surgical mask was not sufficient to stop coronavirus because coronavirus could get between the fibers of a conventional surgical mask. So that's why we needed the N95s, because they have a higher level of filtration and can stop smaller pathogens, which the viruses are on the smaller end of the scale. Okay? Viruses are typically, but not always, smaller than bacteria. Viruses can also lay dormant for extended period of time and then manifest in illness. So you can literally become infected. You could travel. This is a great way to get a virus, is go fly on an airplane, and if you're in there for more than 3 hours, which is most airline flights, you're sharing a finite volume of air with about 100 other people. Is one of them sick and coughing and sneezing in the back? Well, you just contaminated all the air that you're sharing for the next 3 hours. So, but do you get sick immediately? Well, hope not. That might ruin your vacation. It might be that you don't get sick for a couple of weeks. And that's just because either the virus is too few in number, or it's just waiting to get into the right area or waiting to tether to the right type of cell. Okay. Influenza prefers the lungs rather than the nose. So it takes a little bit to work its way down to the lungs. Okay. Funguses, these are eukaryotic, which is the opposite of prokaryotic. Eukaryotic means they do have organelles and nucleus. So funguses are a little bit more advanced than bacteria. Funguses are also larger in size than bacteria. Funguses are dimorphic. That means there's two forms. There's yeast and molds. And I think we have a mold here under microscope. Okay. Funguses usually are skin ailments, but not always. You can get fungal respiratory infections, which are, in fact, you might have heard of long COVID in the news. There's been some talk about long-term respiratory agents or association with COVID infection. They're finding some of that is actually fungal bronchitis and fungal pneumonia. So it turns out people are not washing their masks as often as they should. But fungus is toenail. I mean, when you hear fungus, if you're not thinking of mushrooms on your pizza, then you're probably thinking of toenails and fingernails and all sorts and that kind of stuff. Yeah, and so that's typically where a fungus usually doesn't penetrate into like the internal organs in the abdominal cavity or in the respiratory airways or things like that. It's usually a surface type infection, okay? And in and around areas that are vulnerable and have high contact rates, or where you're sweating quite a bit, or maybe you don't wash that area, like your feet. If you don't wash your feet and change your socks, then don't be surprised when you get athlete's foot, which is a form of fungus, or you just get fungal toenails and your toenails turn yellow. It's because you're not keeping your feet clean. Okay? Parasitic protozoa, these nasty things, okay? Parasitic protozoa are eukaryotic, okay? So they also do not have nuclei or organelles, but they do hunt. They have motility mechanisms. So they have flagella or little finger-like projections, okay, that can move them along through an environment, whereas most of the other types, funguses, I think, can grow in a certain direction, but they can't really move. Everything else depends upon passive motions of whatever medium they're in. So, like a little bit of skin sweat or the mucus inside your nose, as that shifts position, the bacteria in it kind of goes with the flow, so to speak. Parasitic protozoa are different. They can actually choose a direction to move in and move in that direction, which is kind of scary. Okay, they will eat your food from you. So if you get parasitic protozoa in your gut, then you're going to be malnourished because they're going to start eating all the food that you're expecting to provide nutrition to your body. That nutrition is actually being gobbled up by the parasitic protozoa. Okay, so classified by their motility, and I did say all of them, the sporozoans do not move. So amoeboids, those are amoeba. They have pseudopods or false feet. Flagellum, that's a whip-like tail. The cilia, those are the little finger-like projections all around the single-celled organism that propel it with wave-like motion. Okay, and then sporozoans, those don't have a motility. They rely on passive motion of the medium that they're in. Okay. Establishment of infectious disease. How do you get sick? Well, this is how you get sick. There's got to be an encounter. First, you have to be in the presence of a pathogen. That's pretty straightforward. They don't just, manifest inside your body. You have to actually come in contact with this stuff. They have to enter your body. Skin cuts, mucous membranes, the nasal passage, the mouth, the ears sometimes, the eyes, any cuts or scrapes or abrasions or punctures. Those are your major points of entry. The fingernail and toenail beds for funguses, yeah, that's relatively they're entering. They're getting under the nail bed. So spread, that's just the formation of a colony. They find a nice habitat for themselves inside your body, whether it's in your nose or in your bronchus or even in your gut, and they start replicating themselves and absorbing available nutrients from the environment and making duplicates of themselves, okay, in the various mechanisms I just described. So when they do that, then some of they form a central colony, but they also migrate and spread. And so eventually they go systemic. Now, spread within the body is somewhat contained, but again, it depends on the strength of the immune system, and damage depends on the strength of the immune system. So every time you get the sniffles, are you guaranteed to get bronchitis? And the answer is no, and that's because your immune system tries to mitigate the spread. When you get a rhinovirus in your nose, you get an inflammation response. The inside of your nose kind of congests and closes off. The membranes are swelling. You're bringing more white blood cells in to fight the virus, but also to contain it and keep it from going into your lungs. The entire inner lining of the respiratory system is designed with the mucus and cilia system lining to move contaminants out of the lungs constantly. And that's because the lungs are the vital tissue for oxygen and carbon dioxide exchange. We don't want infection in the lungs, but the whole point of the nose is to house the infection that would otherwise get straight to the lungs. Okay? So as miserable as you are with the sniffles and a head cold, it could be much, much worse. It could be into your lungs. So damage and outcome, again, who are we dealing with? Is it an 80-year-old person who just had chemotherapy? Well, they don't have much of an immune system at that moment in time. So the damage and the outcome could be a worse story than a 20-year-old that someone sneezed in their face on the subway. Okay? So those last two really depends on the specifics of what type of contaminant is it, how close contact were they when they encountered it, how much did they encounter, what's the status of their immune system, do they have any other health issues, that type of stuff. Okay. So encounter manifests as a couple different ways. In infection control theory, there's direct and indirect encounters. So direct encounters are you're coming in direct contact with the patient's skin, blood, or body fluids. This includes droplets that they are sneezing or coughing into the air. Those are considered body fluids. Okay? So indirect is where a sick individual, not an ill individual, that type of sickness. Let's say they have a runny nose. They don't have a Kleenex, so they wipe it with the back of their hand, right? Or, God forbid, with the tips of their fingers. And so now they have mucus on their fingers, right? And they kind of wipe it on their pants because they haven't learned any hygiene habits since about 5th grade. Okay? So there's still contaminated mucus on their fingers, and then they reach and grab the doorknob and twist it and bang, now the doorknob is contaminated with rhinovirus. Okay, and so those of you that are parents understand that public schools are petri dishes, and if one kid has the sniffles, it takes literally like 4 days, and every kid in that class has the sniffles, and that's because kids don't have infection control habits and they're not mindful of clean versus dirty surfaces, right? And yeah, a 5-year-old, if they have a runny nose, they're going to wipe it with their hands and then wipe it on their pants and go right back to playing like nothing's a problem, right? So entry is it gets in, okay? Ingression or penetration. Ingression is ingression is more of a passive, whereas penetration is more of an active. Penetration is what happens when you have like a cut or a wound. The bacteria, the microbes that you have on your skin surface penetrate into and under the what's it called? Is it called that endodermis or exodermis? I can't remember. The outer, it penetrates through the outer layer and into the dermal layer, and possibly even into the subdermal layer, okay, where connective tissue is and adipose tissue and things like that. So penetration is, you kind of think of it as less planned. I mean, no one plans to have a cut on their hand and open up their skin, okay? That's a wound. So, but ingression is more like you have to eat, and your food isn't 100%. It's 99.9% clean, but it's not 100% clean. So, in order to eat, you're going to have to put things in your mouth, and we hope that they're mostly clean. Okay, so that's ingression. All right, now spread. Spread is where your immune system can really check the chain of infection. A healthy immune system will stop the spread and keep it localized. Okay, a good example again is the nasal passages. Upper respiratory infections, sinus infections, while they are a pain, they are better than lung infections. Okay, and the reason they're not lung infections is because of your immune system response. Okay. Um, Getting it contaminated into the bloodstream, the spread is a little bit harder to check because you can't really stop the bloodstream. So multiplication, that's what these things do. When they take in nutrients and resources from their local environment, one of the things they do is make a copy of themselves. If it's a virus, it doesn't do that directly, but all the other ones do it basically directly. They make copies of themselves. Okay. An incubation period is usually when you have a small amount of pathogens in there. They're multiplying, but they're not at a population large enough that they're actually producing any side effects yet. So that's the incubation period. Like rhinovirus has got an incubation period anywhere from like 3 days to 2 weeks, depending upon your immune system and your encounters and so on and so forth, and your age and various other factors. But if someone sneezes in your face and they have rhinovirus, you don't get it that afternoon. It's not that automatic. It has a latency. You're not quite sure if you got the infection yet, and then all of a sudden it flares up. The lag before you from exposure to seeing symptoms is called the incubation period. It's basically when the colony is growing and expanding. When it gets to a large enough number of pathogens, then it starts affecting how you feel. Okay? So damage can be direct or indirect. The exotoxins, that's direct damage. And then an immune system response always produces tissue swelling. And tissue swelling can inhibit cellular metabolism. Okay, so it could damage cells. It could also cause cell death through aggressive inflammation. Okay? The exotoxins can cause cell death if they're high enough. Remember, those are poisons to us, and if they're in high enough concentration, then they can kill healthy body cells. Outcome. Basically, this infectious process goes 3 different ways, depending upon a wide variety of factors. Okay, either the host gets control of the infectious agent and wipes it out, the infectious agent overcomes the immune system, and you start suffering from the disease. Now, are those static outcomes? No, you can be wavering between the two depending upon how much external help you get, healthcare you receive. If you're getting a prescription medicine, either an antiviral or an antibiotic, it's going to lean you toward the first option, okay? But as long as the sinus infection is left untreated, it's just going to fester and you're not going to feel good. So the second option, okay? Go get the steroid shot, go get the antibiotic, and then you can get back to the first option, okay? And then finally, the symbiosis state. What the heck is that? Well, the bacteria in the gut, the acidophilus that's in yogurt, is also helpful to digestion. And it's a symbiotic relationship with a human being. So when you have a good gut bacteria, you actually digest your food better, and you get more nutritive value from it. And that comes from a healthy colony of gut bacteria. Okay, you can overpopulate that, or you can underpopulate that, depending upon your diet and your medications that you're taking, your age, and other factors. Okay, so there is some symbiosis. Okay, symbiosis means a partnership type relationship where there's no real damage being done on either side. All right, our chain of infection, we have to have a host. Okay, every microorganism, in order to cause infection, there's got to be a host. There's got to be an infectious microorganism. There's got to be a mode of transportation. I mentioned doorknobs, inanimate objects. Those are called fomites. Okay. Other organisms like mosquitoes and rats and vermin, we call those vectors in healthcare. Those are also modes of transportation. Hopefully you won't encounter any rats in the hospital. Okay. We need a reservoir. The reservoir is basically any contaminated material. Okay. So it could be the mosquito's blood. It could be the patient's blood. It could be the patient's sweat or saliva. A reservoir is it's usually a fluid medium, some kind of water-based medium, where the microorganism can thrive and sustain itself while it's trying to get into the body and start the infection. Okay. So our different routes, air, that would be TB, which is different than droplet. Droplet is aerosolized water particles, very, very tiny water droplets. Okay, mucus droplets, saliva droplets, essentially water. Okay, with pathogenic contaminant. Okay, those they hang in the air for about 30 seconds after the patient has coughed or sneezed, but you got to be within like 3 or 4 feet of the patient, and droplets can be stopped by mask most of the time. Okay. Transmission may be exogenous or endogenous. Okay, so it can come through a cut in your skin, or it can be ingested in your digestive system or enter through your respiratory system. Okay? And then vectors versus fomite. Vector means vermin, but we don't say vermin in a healthcare setting because that gives bad rapport with the patient. So we change it to vector so they don't know what we're talking about. But it's literally cockroaches, fleas, ants, spiders, any other insects, mosquitoes, rats, mice, bats, basically any critter that's carrying disease. Okay, raccoons are vectors. Okay, yeah, just about if it can bite you, it's a vector. Healthcare associated infections. These are called nosocomial. Okay, a nosocomial infection is a hospital acquired infection. Those are the ones we want to target and stop. Okay, iatrogenic means sloppy practice by a doctor in particular. So it's a subset of nosocomial. Compromised patients, medical personnel, patient flora, contaminated health environment, interventional procedures, all these things. These are the things we have to worry about. So our compromised patients, we might have patients with a poor immune system. Anyone who's just had chemotherapy has tanked their immune system. So we need to be aware of that. We have to have a special status for them. There was on called reverse isolation. Okay. Our medical personnel are the ones in charge of breaking the spread of nosocomial and iatrogenic infection. And you do this by washing your hands before and after every patient contact and wearing the personal protective equipment when appropriate. The patient always has microbial organisms on their skin and in their body fluids. That's what we mean by standard precautions. Every patient contact is a potentially transmissible contact of a pathogen. Okay? So we need to operate as if the entire healthcare environment is contaminated. Okay? In interventional procedures, we're going to raise the level of cleanliness to aseptic technique. Okay? And then finally, bloodborne pathogens, hepatitis B and HIV. They are hemophilic. They love to get into the blood. And so they're called bloodborne pathogens. If you come into contact with blood or body fluids, those individuals infected with hepatitis B or HIV, the transmissibility is through the roof. And so we got to be very, very cautious and very, very deliberate with our PPE and our actions in dealing with patients that are infected with bloodborne pathogens. Okay. Environment, therapeutic regimen, how often is the patient bathing and washing their own hands? Equipment, is the equipment we're using, is it sanitary? Has the doctor disinfected his stethoscope from one patient to the next? Because you lay it against the bare skin of the chest, well, it comes in contact with sweat that might be colonized with bacteria, and then he goes right to the next room over and he listens to the next patient. So he just transferred the pathogen and cross-contaminated because his stethoscope was not disinfected every time. Okay? So we need to keep the environment clean and orderly. If it's trash, it goes in the trash. If anything is spilled, then we clean that up. Body fluids are cleaned up and mitigated from the environment. If there is contamination during a medical procedure, that's a very risky situation. So we need to be mindful, especially with invasive procedures, that there is a risk of contamination, and we need to practice good aseptic technique. So some of those interventional procedures will be indwelling vascular lines, thoracostomy tubes, indwelling catheters. That one's in red because that's the highest source of nosocomial infection. Vascular catheters, endotracheal tubes, and endoscopes. All of these are supposed to be set up under sterile technique, but they're all compromising factors that can lead to infectious process. Okay. All right, so that was the hospital factors. Now, our patients, if they're older, they're more likely to get a nosocomial infection on average. Heredity, certain races are more susceptible to certain types of disease. Nutritional status, are they malnourished? Well, their immune system is probably compromised if they're malnourished. Stress, if they're X-ray students, their immune system is probably compromised because the amount of work that they're responsible for. Okay, inadequate rest or exercise. So I repeat myself, if they're X-ray students, their immune system is likely compromised because they're up all night studying and they don't have any time for exercise. Personal choice habits. Does the patient smoke or drink? Okay. Do they eat healthy foods or do they eat potato chips and soda pop? Judging, totally judging. But I love potato chips and soda pop, just saying. Health history. Do they have any chronic conditions? Okay. Are they suffering from another infection at the same moment? Because your immune system can only handle so many enemies at once. Okay. And that's a lot of the trouble with HIV infection is it's a virus that destroys your immune system. So you don't actually die from the virus, you die from bacterial pneumonia because your immune system is crippled by the virus. But the virus doesn't actually, it enables other infectious process. Okay. Inadequate defenses for the above 4 bullets. Okay. So all from nutritional status all the way down through health history, all of those contribute to a weakened immune system. Okay. We need to pay special attention, like I just said, to bloodborne pathogens. If a bloodborne pathogen transmits, we automatically know that it's a nosocomial or healthcare acquired infection. Okay. In particular, HIV and HBV are extremely contagious through blood and body fluids, excuse me. And so when we're handling blood and body fluids, we always want to be wearing gloves, but we will also, if they're on an isolation status, we always want to check to make sure or to confirm their status, whether or not they are, if they do have infection of a bloodborne pathogen. Are they HIV positive or HBV positive? Okay? Because we want to be very diligent with our infection control for both ourselves, but also the equipment, the image receptor, everything. We do not want to transmit HIV or HBV or anything else, but these two in particular, because these two are also lethal. And they're chronic, they're long-term, and eventually they result in patient death. So that's why we're concerned about them. All right, so HIV is a virus. It infects your white blood cells, your T cells. The particular type of T cell is the CD4+, which is a hunter cell, kind of like your own parasitic protozoa. Your white blood cells are classified as phagocytes, which means they eat contaminants. So viruses, bacteria, parasitic protozoa, all these other, funguses, any other infectious agent, the job of the white blood cell, the T cell, is to attack those things, surround it, and then gobble it up in pieces, okay, and digest it, okay? So the viruses, the HIV virus specifically targets this hunter cell and takes it over. And so the immune system tanks. You will get weight loss, muscle and joint pain, glandular pain and swelling, night sweats, okay? It has a long incubation period. Okay. You may be asymptomatic after exposure to HIV for as long as 10 years. It may take up to 1 year for results of blood tests to become positive for HIV antibodies. And so it's really, really hard to detect it. Once we have detected it, you've already had it for a year. Right. Hepatitis B is inflammation of the liver, B class. So there's I think there's 3 or 4. I know there's A, B, and C. Hepatitis A, hepatitis B, and hepatitis C. Hepatitis B is bloodborne. Okay. All variations of hepatitis involve infection of the liver. Okay. The patient will get weakness and fatigue. Your liver is actually responsible for metabolizing all of your body nutrition and metabolizing medicine. So if it's compromised, then you're going to be weak, fatigued. You're also going to have a incomplete immune system because you don't have appropriate nutrition. The liver also produces bile, and the bile starts getting into the extracellular spaces and the skin tissue. You can see it in the cornea of the eyes and the fingernail beds most clearly, but the skin starts to take on a yellow color, and that's because of the bile stacking up in the extracellular space, and that condition is referred to as jaundice. It's a sign of liver disease, possibly liver failure. For hepatitis B, the incubation period is about 2 to 6 weeks. Okay? Some patients will be asymptomatic carriers, and so there are some people who have hepatitis B that symptoms never manifest. Okay. Patients can recover from hepatitis B. We have good treatment regimens for hepatitis B. We also have good treatment regimens now for HIV, which is very, very different than my teenage years. So we're thankful for the advances of medications and pharmacology. It's a different world now. So patients can recover from hepatitis B in 6 to 8 weeks, but they'll always have hepatitis B antibodies, and they'll always have latent populations that they might have flare-ups, but they'll always have hepatitis B. Okay? So our defense mechanisms. We have internal mechanisms, mechanical barriers. So some of the internal mechanisms are like your stomach is always filled with acid. That's a chemical process and an internal mechanism. A mechanical barrier is the mucus lining of your respiratory airway and the cilia that moves the mucus out of the lungs. Okay? Cellular processes, cells, body cells, certain body cells excrete mucus, certain body cells excrete acids, other body cells and tissues can excrete inflammation enzymes that trigger inflammation response and bring the white blood cells into the tissue. External mechanisms, the outer layer of your skin, 5 to 15 cells deep, is all dead skin. That's an internal. So bacteria on your skin can invade all it wants to. It's invading dead tissue. So normal microbial flora. You have gut bacteria, you have respiratory tract, not necessarily pathogens, but microorganisms. Funguses and bacteria always compete for the same food source. So there's always other microbes that are keeping microbes in check, so to speak. Okay, there are non-harmful microbes that are controlling populations of harmful pathogenic microbes. Physical methods: wash our hands, wear our personal protective equipment. Chemical therapeutic agents: these are disinfectants. They're called bactericidals or bacteriostatics. Bactericidals kill bacteria. Those are our organic bleach wipes. Bacteriostatics, those are our alcohol foams. Okay. Immunizations: we can get vaccinated, and our patients can get vaccinated against certain types of disease, and what that does is it promotes an antibody response in our immune system. The antibodies identify pathogens faster than pathogens that have already been encountered, faster, and trigger an immune system response because the antibodies are flagging the pathogens. Okay, so if you encounter a new pathogen, you don't have antibodies to it yet, which is like a flagging agent. But once you encounter a pathogen, your body naturally makes flagging agents that your cells can produce when they encounter the same pathogen the next time. Okay. That's why rhinovirus is typically not that serious, is because you've literally encountered it thousands of times. You have antibodies for it. All right. We can't, a lecture on infection control can't be complete without acknowledging the cruelty that was foisted on Dr. Semmelweis. Dr. Semmelweis was a Hungarian physician. He noticed in the hospital, I think it was the hospital in Vienna, he discovered doctors would deliver infants in the maternity ward and then go back to perform dissections of cadavers, and they wouldn't wash their hands in between. He instructed the doctors to wash their hands before delivering a baby in chlorinated lime. The other doctors took offense that they could possibly be the cause of the high infant mortality, and they blacklisted him. They all grouped up together in a mob action and had Semmelweis declared mentally insane. He was institutionalized in a mental hospital, which in the middle of the 1800s, no one was watching for the health and well-being of the patients. He was physically abused by his staff. He developed a wound as part of one of the altercations. The wound developed gangrene, and he passed away. Okay, this was 1847. Less than 15 years later, Louis Pasteur in Paris publishes germ theory that proves Semmelweis was correct. What an awful, awful thing that happened. And so remember Semmelweis' name, and remember all those healthcare professionals that you're going to encounter that say, well, we don't have time for safety. We need to just get this done. I want you to remember Dr. Semmelweis. Do you have time to wash your hands? Please do. All right. All right, transmission-based precautions. If the patient had contact precautions, that's typically just a little bit above universal or standard precautions. They used to call them universal. Standard precautions are for everybody. You wash your hands and you wear gloves for everybody. Okay, contact precautions. You also have to cover your clothing with a protective barrier, so you have to wear a paper gown. Okay. Contact precautions usually means the patient has an infection and it's on their skin surface, or we're going to find it in their bed linen. Okay. Droplet precautions means the patient has a respiratory infection, and as they cough and sneeze, they're going to produce infectious droplets. When you get to droplet precautions, you have to wear a surgical mask. Okay? The patient should be wearing a surgical mask if they're not on oxygen. Not for airborne, for droplet precautions. For airborne precautions, you need to wear an N95 mask because tuberculosis can get through a conventional mask. Okay? Droplets are too big, they can't get through a conventional mask, but tuberculosis is small enough that it can, and so you need an N95, which is it's a tighter seal, it's a more dense fiber that makes up the N95 respirator mask. So airborne precautions, and the last I knew, COVID positive was modified airborne. So you have to use N95 respirators for COVID positive patients as well. Asepsis. These are levels of cleanliness. It could be the environment, it could be you and your hands in particular. Okay, so surgical asepsis is the highest standard. It's complete elimination of microbial populations. In the instrumentation you're using, on the work surfaces you're using, and your hands and anyone else who's helping you, their hands too. Okay? So it's a more rigorous level of asepsis. Medical asepsis is a step down from surgical. It's disinfection. It's reduction and slowing down of the presence of pathogens and contaminants. Okay. Hand washing. Hand washing has a specific routine to it. You have to lace your fingers. You have to flip your hands over and scrub the back of your hands. If you're wearing a ring, the ring has to come off because you won't get soap under the ring. Okay. If you're wearing fake fingernails, you are harboring fungus. That's why fake fingernails are not allowed at X-ray school. I will run a quick lab on hand washing, and I think we also have a video that I'm going to share with you later, a collection of videos, and one of them is about hand washing. As far as disinfecting the environment and establishing medical asepsis in our exam room, we want to use the disinfectant wipes to wipe down the table, the image receptor plate, the vertical image receptor, and the X-ray tube. The X-ray tube controls basically anything, and the doorknobs to the exam room. Anything that a hand touches during the course of an exam, we want to wipe that down at the beginning, at the end of all exams. In addition to washing our hands. Okay, when we do that, we're interrupting the chain of spread by eliminating the presence of fomites. Okay. Physical methods of asepsis, that would be the instrumentation used in surgery. It either comes as a pre-manufactured pack, like a lumbar puncture tray, or the instruments are sterilized in sterile processing by the use of autoclaves, which are basically just high-pressure steam ovens. Okay, moist heat is the most effective method of sterilization. All right, sterilization, or achieving surgical asepsis, is the process of killing all life forms. So whether it's a pathogenic microorganism or a friendly microorganism, we're just going to kill it. Moist heat with pressure is the most effective method, and that's what the autoclave provides. It is a high pressure steam oven. Okay, it's like a pressure cooker. Ultraviolet light is also extremely effective. Okay. Standard precautions incorporate both the features of both body fluid precautions and body substance isolation. Should be used when performing procedures that may require contact with blood, body fluids, secretions, excretions, mucous membranes, and non-intact skin. Every X-ray procedure is a standard precaution procedure. Give me just a second. All right, so standard precautions include hand washing, gloving, personal protective equipment, which the gowns usually aren't required till we get to contact, but they're optional. You don't recap needles, and biospills are handled appropriately. So if the patient vomits in your exam room, it needs to be cleaned up, but it needs to be cleaned up and disinfected. Okay. So environmental service needs to be called, and that doesn't mean you just leave it for environmental service. You attempt to clean up, but they need to make sure that the area has been disinfected. That's their responsibility. So they're supposed to follow along with a mopping and a wiping down of the exam table or wherever the vomit got to. Okay. Okay, so you're going to encounter somewhere between 10 and 15 patients a day. How many of those have the sniffles or HIV or hepatitis B or whatever? So we always assume that it's a possible transmission. And so the best practice is hand washing before and after every patient contact. Okay? When in doubt, wash your hands. Okay? The most successful stoppage of the spread of pathogenic microorganisms is good hand washing protocol. Okay? So if you adopt good hand washing protocol, then you are participating in infection control and you're doing the absolute best thing you can do to prevent the spread of disease. Okay? So hand washing needs to become a habit. Okay? And if it's good enough in the healthcare setting, is it going to improve your personal health too if you're always washing your hands? Yes, it will. But my question is, why aren't you washing your hands? Okay. So transmission-based, contact-based, airborne, droplet, those are steps over and above standard precautions. Okay, so standard precautions is everybody, but then these are additional requirements. So the airborne, droplet, and contact, those are additional requirements. For the contact, you have to wear a gown. It's not optional. Okay, you don't have to wear a gown for standard precautions all the time. Okay, if you want to wear a gown, you're welcome to. No one's going to stop you. Okay, but you don't have to. You should wear gloves for every exam you do. All right. So contact precautions, gloving, and then also if you're wrapping yourself up in a barrier, the image receptor also gets wrapped up in a barrier. So we're going to put a little plastic sheath over our image receptor cassette or image receptor panel, take the x-ray, and that way the patient is in contact with the plastic barrier and not in direct contact with the image receptor. And then that's a one-time use. Once we've taken the image and completed the exam, we discard that protective barrier along with our gloves and our gown. So all PPE is disposable and one-time use only. If you're wearing gloves, you're only wearing them for one patient. If you bring gloves, if you wear the same pair of gloves for a second patient, you're kind of defeating the purpose of the gloves. Okay. All right, so infection, it involves establishment and spread, dissemination, multiplication, spread of a microorganism on or in a host. Okay. The disease process is caused by the presence of pathogens, that is, microorganisms that are hostile to us in various ways. Nosocomial infections are acquired in the hospital setting and are preventable because we can break the spread by adopting the PPE and following the hand hygiene protocols. Human body has mechanical, cellular, and chemical mechanisms that it uses to fight infection. Through aseptic techniques, environmental control of infection is fairly simple and straightforward. It becomes habitual to you, but you have to work to set the habit first, and then it becomes habitual. Okay? So, wash your hands before and after every patient contact. Wear gloves with every patient. Okay? Pay attention to the isolation signs and follow the advanced isolation protocols.